Hi, my name's Danielle Hardy. Today we're going to be discussing the Hamilton ventilators and the correlating documentation. First, I would like to begin with a few objectives. The importance of understanding why this may be different than traditional BiPAP and CPAP ventilators. The Hamilton C1 is PEEP compensated, and with ventilators such as the V60 or BiPAP Vision, these are uncompensated ventilators. We're going to review NIV and NIV-ST on the Hamilton C1 ventilator, along with the correlating documentation in regards to non-invasive ventilation on the Hamilton C1 ventilator. The following is terminology that we as respiratory therapists already understand. I just wanted to review. Do understand that pressure support and P-INSP are the same thing on the Hamilton ventilators. Delta P is your delta pressure, but it's also known as your change pressure or drive pressure. The peak inspiratory pressure is also known as positive airway pressure or total pressure. Anytime you will be providing pressure onto a baseline, the ventilator needs to understand where it is going to stop at. For example, anytime we are going to dial in a pressure control or pressure support setting, the PEEP compensated versus uncompensated ventilator becomes very important. And let me tell you why. We're going to apply the above settings to a PEEP compensated and then to an uncompensated ventilator. And I'm going to show you what your pressure waveform will look like and how it is going to differ. So we said here we're going to set a PEEP of 5 and a pressure support of 15. In the compensated ventilator, we're coming along with a PEEP of 5 and our patient is going to take a breath in with a pressure support of 15. The ventilator is going to take that pressure support of 15 and increase the pressure and apply it on top of the PEEP of 5. So you can see the delta P, also known as the drive pressure or change pressure in this scenario, means that it is 15. This means also that our peak inspiratory pressure or total pressure equals 20. We are compensated and the ventilator understands I'm going to put this 15 of pressure support on top of my PEEP of 5. Now we're going to go to the uncompensated realm. We will start again by setting the PEEP of 5 and we're going to have the same setting of pressure support of 15. This is what our pressure waveform will look like. See, now here the ventilator only rises up to the pressure support setting. The ventilator understands and it only functions to understand that the pressure set is what it will rise to. And in that case, it is 15. The reason this is important is if you look closely, we only have a delta P or change pressure of 10. Because we are set at 5 and raised to 15, the only difference here is the change pressure of 10. That means our total pressure or PIP is 15 centimeters of water. Overall, you can see even though these settings are the same, what is actually happening to the patient is not the same. The compensated ventilator results in a greater tidal volume, thus having a greater impact on minute ventilation, more so than the uncompensated ventilator. To recap, compensated ventilator, the pressure control or pressure support is above the PEEP. In the uncompensated ventilator, whatever you have set is the total pressure delivered, also known as PIP. In the V60 and in the BiPAP Vision, this is also known as IPAP. And remember, the V60 and the Vision are both uncompensated ventilators. So now with this understanding, you can also apply this in pressure control if you're utilizing an invasive mode of ventilation on compensated and uncompensated ventilators. Now, let me give you one more example here. In this case, we have the same patient and we increased our PEEP to 10. This is the most important part of why it is important to understand the difference between both of these types of ventilators. As a respiratory therapist, your modifications could significantly impact your patient. So, in our compensated ventilator, we set a PEEP of 10 and our pressure support above our PEEP we set to 15. This now makes our total pressure or peak inspiratory pressure 25. Our delta pressure or change pressure, also known as a pressure support, remains at 15 in the compensated ventilator. Now let's go to our uncompensated ventilator on the right. We set our PEEP at 10, so it begins at 10, and our pressure support, or the terminology utilized in the V60 or Vision is IPAP, is 15. So our pressure rises to 15, and now our delta P, or our change pressure, is only 5. This obviously can significantly impact ventilation. So why does this happen? When we increased our PEEP to 10 from example 1, we reduced our delta P, or change pressure, which reduces our tidal volume, which impacts our minute ventilation. Our patient now has to work harder in the uncompensated ventilator to sustain or maintain the same tidal volume. So, in our uncompensated ventilator, our PIP, or total pressure, is 15, or whatever you have set. The big question asked often is, how do you know if the ventilator you're working with is compensated or uncompensated? And the answer is actually very simple. If it is compensated, the pressure control or pressure support set plus your PEEP is your peak inspiratory pressure or total pressure measured. So, if our pressure support is set to 15 and PEEP is set to 5, then our peak inspiratory pressure should be 20. This is the way compensated ventilators work. If you're working with the uncompensated ventilator, then your set pressure is your PIP, or total pressure. So if we're setting a pressure support of 15, or the terminology utilized in the BiPAP Vision or V60, the IPAP is 15, then our total pressure, or PIP, should be 15. In the photos above, we have placed both ventilators on non-invasive ventilation spontaneous time, with the settings of 20/7 and a rate of 16. In the Hamilton C1, the pressure supports, or PINSP, that is set is 20, and the set PEEP is 7, equaling a total pressure, or peak inspiratory pressure, of 27. In the V60, the IPAP set is 20, and the set PEEP is 7. And if you can view, the PIP is 20, as the ventilator is recognizing the total pressure set is 20, as the V60 is an uncompensated ventilator. There is a key difference on the total pressure delivered here, as well as the change pressure. So if you are used to utilizing an uncompensated ventilator, you need to be able to understand all of what we just discussed for when you walk into the realm of a compensated ventilator when it comes to peak. So now that we have a good understanding of the difference between compensated and uncompensated ventilators, how do we document it during patient assessments? Now we're going to utilize the previous screenshot. Even though we most likely would not want the patient on these settings, we're just going to review the parameters. So please remember, this is just an example. So in the top left-hand corner, our peak inspiratory pressure, also known as our total pressure measured, is 27. Our PIMPS, also known as our pressure support, which in the Hamilton models correlates to change pressure, is 20. Our PEEP is set at 7. So if we look on the right in our flow sheet, the ventilator utilized is the C1, the patient is on BiPAP, the FiO2 is set to 21%, but we have to document that we are setting a pressure support of 20, or PINSP. In the Hamilton ventilators, we do not set an IPAP, and we also do not set a PIP. So this has to remain blank. We do set a PEEP, and that is 7, and our total measured is 27, as on the left of the screen. Let's look at this closer again. We are not setting an IPAP, and we are not setting a peak inspiratory pressure setting here. We are setting pressure support, or PINSP, depending on the mode. So document what you are setting on the ventilator itself and the monitored values. So now we're going to dive into some clinical scenarios. Here we have a 53-year-old female. She presented to the ED via EMS with shortness of breath on 2 liters. She has a history of end-stage renal disease, is on hemodialysis, obstructive sleep apnea, and heart failure. Her vitals on arrival: heart rate of 119, respirations of 33, and a saturation of 89%. And the ED physician requests the patient to be placed on CPAP. You place the patient on CPAP of 12 and a FiO2 of 35%, and you notice improvement in the worker breathing and saturation, so you are now set to document. So let's look at our settings and our monitored values here in this scenario. On the right hand side, you will notice the flow sheet that we have. So this patient came in, respiratory failure. We write our biomed number. We know it's a C1 ventilator. They're on a face mask. They're on CPAP with a FiO2 of 35%. Here, even though the patient is on CPAP, we have to look at what we actually set. So the pressure support is set to 0. You have nothing there. And the patient's PEEP is at 12. And the total measured is 12. So we have to think about, should we document CPAP or PEEP? And here I would like for you guys to document what is on the ventilator itself. In the future, the VCG is going to be looking at to add CPAP to the terminology of the EPAP/PEEP row. Right now they're currently separated, but this is going to take some time with upgrades in Epic. Moving on to clinical scenario number 2, we have a 72-year-old male. He presents to the ED via EMS. He's short of breath, is receiving a duodenum treatment upon arrival, has a history of COPD, wears HOMO2 at 3 liters. Vital signs are as follows: heart rate 133, respirations of 28 with a saturation of 90%. The ED physician requests the patient to be placed on BiPAP due to accessory muscle use. You place the patient on non-invasive ventilation, 6/6, and FiO2 of 35% with improvement in worker breathing and saturations. We do need to remember that the pressure support set in the Hamilton C1 is also the change pressure, drive pressure, or delta P. And we also need to remember that the pressure support plus the PEEP is the total pressure delivered. Now let's go document our settings. So if we look at the right hand of the screen, we have our flow sheet again. Patient's FiO2 set to 35%, but note that the patient is on BiPAP this time. So we did set a pressure support setting, and that is 6. We did not, however, set an IPAP or a PIP setting technically, and we did set a PEEP of 6. The total pressure measured is 12. So this is what we should document on the Hamilton C1. Moving on to clinical scenario number 3, we have a 41-year-old male transferred to the ICU, COVID positive. He's been on 60 liters, 50%, has accessory muscle use, is working pretty hard. His vitals on arrival, heart rate 128, respirations of 28, and a saturation of 84%. His breath sounds are scattered fine crackles bilaterally with diminished lung sounds in the bases. The physician orders for the patient to be placed on BiPAP. So once again, we need to remember the pressure support that is set is also the change or drive pressure or delta pressure. We also need to remember that in the Hamilton C1 as a compensated ventilator, it is the pressure support plus the PEEP equals the total pressure. So now let's go document. So reviewing the flow sheet on the right side of the screen, same scenario, the patient's on BiPAP, they're on a FiO2 of 50%. We need to document a pressure support setting, which is 10. That's also our change pressure. We need to document a PEEP of 5, which we have. We do not document an IPAP or PIP setting here. And we need to document our NIV or peak inspiratory pressure measured, which is 15 in this case. So to review and to conclude, the Hamilton C1 ventilator is a PEEP compensated ventilator. Our set pressure, which could be our pressure support or pressure control, plus our PEEP equals our total pressure or PIP. Now we understand how to document when utilizing the Hamilton C1. We do not utilize an IPAP row at all when documenting on the Hamilton C1 ventilator, as that is not what is set.